So I'm going to talk about navigation in spine tumors. So this was back in 2017 when I had just finished my SRship. Surprisingly, immunocompetent guy, student, he comes with such a swelling, which was biopsy proven. They said it was spindle cell tumor. We struggled, but eventually we removed an entire capsulated mass, which turned out to be a cervical leiomyoma. And this was back, I think, 7 years ago before I started my ASSI fellowship. Then I went into my fellowship. As he said, Tomita, Tokuhashi, everything's obsolete. So now we don't use that anymore. But what is the best mode now? Image-guided procedures are the basis of modern spine surgeries. This was given back by the Rizzoli group in 2013 when they had first started using navigation. So why navigation now in spine tumors? That's because you have accurate placement of implants like any other surgery. The three-dimensional orientation of disease, that's an absolute, when you are dealing with a primary tumor, this is something that you want on table, and you cannot have the 2D fluoroscope in and out every time just to have an orientation about the tumor, which is anyway infiltrating. And identifying and determining to what end are you going to get an R0, or will it be an intracapsular excision? How do you proceed? So metastatic tumors, I don't remember doing an OR block in the past 70 cases that we've done in the past 4 years, thanks to Tata Memorial, who refer us out. But we have not done an OR block resection because of good radiotherapy, as he said, and immunomodulators. We have so many immunomodulators now that RCC is being treated literally by oral drugs now, and they have increased the survival even when it's metastatic. So we all know how the 3D CT scan intraoperatively works, and it is integrated with the navigation. Or you can have a 3D fluoroscopy which can be integrated with your navigation system. So tracking during your surgical procedure. Now if you have a complicated case such as this, you would want the CT and MR both to be integrative, so that when you pinpoint that place, you should be absolutely sure whether it's a bony margin or the MRI, because a lot of time the MRI will actually show you that marrow edema, which will not be seen on the CT. So your R0 automatically extends to the normal R0 that you thought your CT was providing. So this merger of the MRI and the scan in this era is absolutely important, especially when you're dealing with primary tumors where you have to get an R0. So besides that, you can always, identify the vasculature, the proximity of the nerves, vessels, and navigation will guide you safely, at least much more safer than you yourself being the human here. So using an adjunct is not a problem anymore, because you are ultimately proceeding towards a safe spine surgery even in tumors. So this is one where the Rizzoli group, they go through their IRs, and then this is how they do their radiofrequency ablation, where they push in the needle. We had this, a lot of people do it. Sir does it, like where they have the O-arm and now they're excising the osteoid osteomas. So this was what I had published with the Rizzoli group back then when I was there in 2019. This was the largest study on osteoids, which was surgical excision versus radiofrequency ablation. So back in the days when we did not have minimal access methods, this is how they used to excise this. This was there around the posterolateral corner of the body, and see how they use navigation. They opened the spine back then they guided it with the navigation, and they excised this difficult location of the tumor, which is difficult. Come on, now it is getting easier and easier because we have more access. But back in the days, I think when navigation was introduced, this was challenging. Now you see this case. This case was there at Tata Memorial. What do we do with such a big tumor here, with so much of infiltration that it is almost extending into the psoas? So we did the MRI, we integrated it with the CT, and this is how it looked, This was the first time when I was introduced to navigation in India. I never had one, so I used to use, go to Tata and, help these guys out, and this is how we removed such a big tumor in a 70-year-old gentleman. So this is like stage 1 of the surgery, where you have excised everything, and you see it has been so infiltrative that there's no muscle left. So that is why we had to stage, and the blood loss was nothing short of 6 liters. So that is more than the blood loss in the human body. But then you can manage such things at Tata Memorial because they are used to such cases day in, day out. This is another lady who had come with a big mass in the cervical spine. They thought that it was a cystic solitary tumor. You see here, this is how I had integrated just to see if there is slight erosion of the lamina here, you know, and that is why I had the MRI cut also just to see that to what end am I expecting the epidural infiltration here. Because if I have to go and if I have to plan this out, I should know my exact margins. That is like the beauty of navigation, this integration of this MRI with this CT scan, which will just give you the right idea to know to what end are you supposed to go. So this was like the lower cut where I wanted to know where there is no tumor whatsoever. Again, it's integrated. So this is what we had planned, that you see when you draw this rough diagram to know what is the extent of your resection. The CT angio was done because there were two feeders which were directly coming from the vertebral artery on that side. So we just had to embolize this patient so that during excision we don't encounter a lot of blood loss. And this is how it had come out later. So here, in fact, even your scalpels and your osteotomes can be attached to that wand, and you can actually make the right cut, you know, but that is only and only after you thoroughly study all these integrative methods, you know. I mean, if you don't have an idea as to what end are you supposed to go here, you will never make that right cut and then get it out R0. So this is what was done, and that's her. I mean, on post-op day 2. So this is what I had to tell you, that the goal of spine tumor surgery can vary because of the tumor and the disease. I would still push you to use this to your fullest when it comes to primary tumors. It really aids the surgeons in resections. Debulking and separation, we all know that it can be done, but it's a much safer play because we have a timeline to give to the patient and we have a lot of adjuncts. But providing accuracy and precision when you talk about ablative therapies, and it is surely a new indispensable tool, at least for the years to come. Thank you.